past, the present, and the future of breast imaging. You're going to be very happy hearing about the revolution we radiologists created. We changed the paradigm. It does not happen every day that physicians can change a paradigm, and definitely not the radiologists. I have a question for you. When was the first breast cancer published? About 5,000 years ago. And this is the Edwin Smith papyrus. The picture of it. It measures about 5 meters, and there are 8 breast cancers published here. Unfortunately, I cannot read this, but I'm positive one of them is here. Between that time point, 5,000 years ago, and 1970, could you describe what happened when concerning the diagnosis and treatment of breast cancer? And unfortunately, you would give one word, and this is such a sad thing. For thousands and thousands of years, women presented with this kind of disease, and even worse, to their physicians when the cancer was too advanced and spread in the body. Systemic. Breast cancer is an adenocarcinoma. From the start, it is not systemic, but it may become, and our job is to stop it, to arrest it anytime we can. Certainly this very smart physician, Hippocrates, could only use one word to describe breast cancer. It's incurable. It wasn't a long time ago I took this picture. And you see these casting type calcifications in the axillary nodes. And the cancer eats her up. Question is, what could the generations of physicians do with these cancers? Really nothing. Whenever you are going to visit Moscow, I would strongly recommend for you to visit a fantastic art gallery called the Tretyakov Museum, where this very talented artist painted this beautiful woman whose name was Bathsheba. I suppose you know who Bathsheba was. Bathsheba was the wife of mighty King David, who was rich, who had power. But Bathsheba looks very different on the front page of this book written by an American author. And I would strongly recommend for you, all of you, and all the technologists and nurses working in your breast center to read this book. Because this is the only book that very professionally leads us through the 5,000 years. Why does Bathsheba look like this? Because the artist is so skillful. Look what's here. Bathsheba died from breast cancer. So not only this example, but many other examples during the 5,000 years show that money or power could not stop this disease. If we are hopping over a few thousand years and go into the Middle Ages, where a very talented painter, Raphael, had his girlfriend, La Fornarina. Raphael died at age 37, and La Fornarina died at age 32. Look at the artist again. What did she die from? Advanced breast cancer. So this was the past. Unfortunately, this is the present in many, many, many places. It's not difficult to collect pictures such as this one. But it should be the past, and it can be the past, and that's a part of my lecture. Now we go to, at that time, very advanced country, the United Kingdom, where the surgeons wrote a book, Modern Surgery. And I'm shocked that they are using exactly the same word Hippocrates used. This is a hopeless disease. And that was just about 170 years ago. So now we arrive to the 1970s, when this ingenious low-dose film screen mammography was invented. And then we found hundreds and hundreds of microcalcifications, baby cancers, stellate, circular lesions, and we were so happy because that was the only time we saw some hope, some light at the end of the tunnel, that we are going to be able to steal time from cancer. The era of advanced cancers is going to be over, and then we are going to save lives. Yes, indeed. I'd like you to feel very, very good, because during the 5,000 years, there has never been any physician generation but ours that not only committed itself to change the breast cancer patients' outcome significantly, but we really do it. And let me put my foot down. It is not because of radiation, and it's definitely not because of chemotherapy. It's because of, we go back in time. She already has the disease, but she doesn't know about it. But we can arrest this disease. We are finding cancer in an early stage. So the arch enemy is the advanced cancer. Please remember this word, French, sojourn, that is journey, means sojourn time, as professionals call it, is the growth rate. How many months, how many years does it take for the baby to become a grown-up, potentially harmful cancer? On one slide, we can describe and demonstrate the revolution we have accomplished here. We have replaced the mainly palpable tumors with the mainly non-palpable. This is what we have to do. When concerning breast cancer, it's too heterogeneous disease. We are not going to be able to act on that circle. And I'm going to show it to you that yes, your oncologists are giving a lot of chemicals, neoadjuvant, and in 80% of the cases, they are just poison and not saving lives. This is what we have to do. It's not a question of competing between early detection and treatment. That's pretty simplistic way of looking at controlling a disease. Treating breast cancer in early phase, when you deliver it, I deliver it, that saves life, not the ongoing overtreatment. So during the decades, physicians figured out that very large breast cancers usually kill, large breast cancers often kill, and baby cancers very seldom kill. So then the theory came up, yes, we are going to be able to change the survival curves and flip them up here. The difference is about 20 times. Her risk of dying from the disease is significantly less compared to the self-detected cancers. Yes, we have the goal. Get rid of advanced cancers. Because there is a parallelism between the rate of advanced cancer and mortality. So actually the outcome measure is not how many cancer in situs we find, how many baby cancers we find. No, how efficiently we cut back on the incidence of advanced cancers. So the theory was arrest the disease, cut back on advanced cancers, and because most of the death comes from advanced cancers, then mortality is going to go down. So we are going to be able to control the disease. Very cruel randomized controlled trials had to be carried out. But as soon as you come up with a brilliant theory, watch out, there will be an opposing theory. And it's quite a shame that the Fisher brothers on the East Coast of the United States came up with this idea that breast cancer is a systemic disease from its inception. I asked Bernie, which medical school have you studied at? Adenocarcinoma cannot be a systemic disease. But now you understand why the oncologist pushed the surgeons aside. A surgeon himself sold out the treatment to the oncologist. Okay? There are two theories. We had to take mortality, not survival, as an endpoint. And the very first trial was carried out in New York. But you see, in New York, at that time, early 60s, the cancers were so huge and the mammography quality was so tremendously poor. So smart enough, they used palpation. And because the cancers were in this very advanced stage, palpation made this downward state shifting. Is this early? Well, it's earlier. And surprise, surprise, there was a 30% decrease in mortality. But then you see in 1970s, this new method came, low-dose film screen mammography. So we not only took this step, but we went further down. And then science comes again and says, yeah, sure, so what? There was a 30% benefit here. Would there be any more benefit here? Is it really worthwhile to push early detection further? This couldn't have been carried out in the United States, and that resulted in the Swedish trials. It was Swedish women who actually demanded screening because the medical journalists published the HRP result, and the women told, we want screening. The cancers were not as advanced in Sweden as in New York. So then the government designed a trial. And then we did something differently compared to the New York trial. No palpation. 200, 300 women a day using the new method, only mammography. I'm going to cut it short. We had to read 1 million women's mammograms in order to be able to publish 8 years after the start of the study that we delivered. That was expected, cut back on an advanced cancer rate, and mortality decrease came with it. By finding the baby cancers, we arrested the big ones, so then it flipped over. And as you see, from year 4, significant decrease in advanced cancer. And surprise, surprise, from year 4, fewer and fewer deaths. Brilliant. So the New York trial, the WE trial, really showed that early detection is effective in reducing breast cancer death. Nowadays, we can be very happy that 8 population-based randomized controls trials showed the same thing. In medicine, there has never been any diagnostic or therapeutic tool that has been scrutinized as much as early detection and treatment in early phase. Well, let's go back to the Fisher brothers, and I'd like to refer to one of our colleagues who have done a lot for early detection of breast cancer, Dan Coopens. He quite recently wrote an article. He referred back to the arcade game, Whack-A-Mole. So I use this. Dr. Fisher states that breast cancer is a systemic disease from its inception. Dr. Fisher, excuse me, both the HIP results and the WE trial showed that diagnosis and treatment of breast cancer in early phase could prevent deaths from breast cancer. Throwing out your theory. And it's very important to understand that the endpoint was not survival, it was mortality. And then the politicians, decision makers, really had to wake up and implement this in one country after the other. So the 2-county trial was really the basis for screenings in many different countries, even the little lazy neighboring country. I'd like to mention something for you. There have been so many anti-screening people who stand up and discuss with you, against you, screening and screening and screening. Don't ever use the word screening. Why don't you use early detection? Because then they become a fool immediately. Yes, breast cancer is not a systemic disease from the outset. It's a progressive disease, and please keep in mind that the newborn baby that is cute, lovable, may become a criminal during the growth. If most of the toddlers are very cute, why do we have prisons out there? Because some of the cute kids become harmful people. And that's called de-differentiation. When you get the accusation that you are finding grade 1 cancer in situ and tubular carcinoma that would never kill, just tell them, wait, while the intratumor heterogeneity is going to change this lesion to a more aggressive carcinoma. I'm going to talk about this anti-screening problem. You heard this word harm. Sure, the biggest harm a poor woman can be exposed to is when letting the baby cancer to become this huge carcinoma. That's a harm. Wonderful article was published by Judith Malmgren and Jay Parrick. The harm of not attending mammography screening, that's much bigger than attending it. So here we are. Aren't you happy? I am very happy that we belong to the only generation of physicians who are not lying to the patients anymore. Oh, just come to me. I'm a doctor. Whatever stage your breast cancer in, I'm going to cure you. Nope, that's a lie. We have to arrest the process, stop the baby cancer becoming an advanced cancer. This is a summary of the past, and let's talk about the present, and later on about the future. I founded a research group back in 1986, that was more than 30 years ago, collected the best brains in the world, Prof. Duffy from the United Kingdom, Prof. Chen from Taiwan University, and his kids, and so on and so on. We had workshops twice every year during 30 years. I really have to give credit to the American Cancer Society because that was funding it. Dear colleagues, here is the end of the story of our randomized controlled trial. We published this in 1985, and then we decided that every second year, whatever the curves are going to look like, we are going to publish. Because nobody has ever had 133,000 women in a randomized controlled trial, age group 40 to 74. Some people still don't understand this is not the effect of screening. We haven't tested mammography. We haven't tested screening. We tested early detection. Among the invited, 15% didn't come. 85% came. And 30% of breast cancer death was in that 15%. So it's invited and not invited. Screen-detected cancers and mortality from that is down there. And we decided that we are going to publish it decade after decade, as long as we are around. So the randomized controlled trials provided unequivocal supporting evidence that this generation of physicians have accomplished something unbelievable. Here is my group. We met in one of the workshops because there are questions that remained. They say, grade 1 cancer in situ and well-differentiated cancers that would never kill. Our research group published. Most of the mortality benefit in that trial came from finding grade 3 cancers. So actually that assertion was taken out of the air, very malignant against you and us. Next question, overdiagnosis. Now that's why we stopped screening at 69, 74, because the expected length of life for women is about 89. If she's 80, then it's another 13 years or whatever it is. Let me just summarize for you. Those professionals who adjust the data for lead time and for the ever-increasing incidence, they find only 1 to 5% overdiagnosis. And those unprofessionals who don't do this, they talk about 30 to 50% overdiagnosis. This caused a lot of trouble, but you should be empowered by our publications concluding that there are no credible data to support the conclusion that there is overdiagnosis. Oh, there is overtreatment, but nobody talks about that. I will. Can you imagine, after so much data, this question comes up. Screening doesn't lead to significant decrease in all-cause mortality. This is a new anti-screening activity. Is that right? No, we examined that one too, and we published that among breast cancer patients, there is a 19% significantly decreased all-cause mortality. But you see, those who ask a question about all-cause mortality, they expect that in the whole society, all-cause mortality is going down. You know very well that mammography, compressing the breast, is a wonderful method. But you cannot expect that death from traffic accident is going to decrease. The question about all-cause mortality is so primitive. But we picked it up and say, among breast cancer patients, all-cause mortality decreases because breast cancer death accounts for a very large proportion of all cause of death. And if you cut back on that by 30-40%, then you got significant decrease in all-cause mortality. You see how I'm going through the questions and very unprofessional questions that plagued us during the past. The present entertains my research group very much, namely service screening. It's service for the people. So we formed this group we joyfully call Sausage, Swedish Organized Service Screening Evaluation Group. Because now there is another question. Mrs. X comes to you and says, I don't understand randomized trial because you included my neighbor who was not willing to come. But you know what? I'll be a good girl. I want to come to you. What's my benefit? What do you give me in case I get a breast cancer? How much will my risk of dying from it is going to be decreased? That's an entirely different question. So I trained colleagues covering about 40% of the country, and I give credit to all of them 15 years after training. In age group 40 to 49, they cut back on advanced cancer rate, and in 50 to 69, they cut back on advanced cancer rate. And therefore, we can report that among women who regularly attend screening, the risk of dying from it is going to be cut back by 43%. Now, for 5,000 years, nobody could touch this disease. If this is not big, I don't know what is big. Published in the United States. But again, it's so important that we look at other screenings. For example, in the Netherlands, just remember that number around 40%. 100 minus 51, 49 in the Netherlands. And when the anti-screening people in Denmark were most active, then the Dutch government asked an independent group of people to come up with an investigation. And the committee concluded that yearly 775 breast cancer deaths is prevented in that small country. But you see, this is one thing. We are talking about absolute numbers. We are talking about relative numbers. But if you have ever seen a breast cancer patient dying, this is much more important for me. The human and economic benefit for the society. That is, when you and me prevent a breast cancer death, the woman is spared the terrible terminal stage of the disease. And she is going to gain average 16.5 years in life. So that was Sweden. That's Netherlands. Norway, you see, Sweden, 43, 49. Norway, around 40. The Pan-Canadian study, 40 there as well. And the newest one, New Zealand, 39. Isn't it a fantastic thing? Around 40% fewer women die. And so it's absolutely shocking that an American surgeon lady, as late as 2013, asked this question, will early detection of breast cancer ever work? Dr. Asserman, is the earth flat? Shocking. Rethinking screening for breast and prostate cancer. Isn't that shocking? Can you imagine the frustration? Such a shame. We have carried out these cruel randomized controlled trials, and now we evaluate service screening. And both of them show unequivocal supporting evidence that early detection and treatment in early phases are associated with significantly fewer deaths from the disease. So now we are working very diligently, answering this question of the individual woman. What's in it for me? What's my benefit? And we published exactly a year ago, November 2018, a new method, the incidence of fatal breast cancer within 10 years. Before screening, this is before 77, breast cancer incidence increased with 1 to 1.5%, very diligently every year. And now during screening, you got the accusation there are more breast cancers because you find more cancers. That's true and not true. Because you see, there are two bars here. Those who are unexposed, incidence is increasing. And those who are exposed, incidence is increasing. We cannot influence this. Every year, breast cancer increases by 1 to 1.5%, irrespective of screening. Don't blame screening for that. But, and now comes the big hammer. Before screening, 55 women died every year out of 100,000. And now screening started, and we split exposed and unexposed. And those who came to screening regularly have nowadays 60% fewer deaths. 55, 25. But, and then you heard that, oh, it's treatment. Excuse me, it doesn't seem to work. Mortality does not decrease among those whose cancer is found in an old-fashioned way, and then modern therapeutic regimens are poured on that. Nope. This is the future. This is not a good number. Women who participate in screening benefit compared to those who do not participate. We are training the providers. Who is giving this information to the consumers? To women, please come, this is your benefit. And we should really stop continuing with this kindergarten mentality. Is it treatment? Is it screening? Both of them. Time to focus attention on the combination of early diagnosis and proper treatment instead of viewing them as independent or worse, competing interests. Those benefit most from the current therapeutic regimens who actually participate in mammography screening. Don't ever forget this. There is no substitute for finding breast cancer early in its natural history. American Cancer Society became so enthused about these results, there was a press release. And now we are not going to stop. That was on the basis of 1 county. Now we are going on to 9 counties and examine mortality in 500,000 women aged 40 to 69. We are working very diligently, and the result is here. Red, non-participants, and this is death, and those who participate regularly. In 40% of the country, this is the result. And it's interesting, if you train the radiologists properly, all of them are going to do equally good job. These are the 9 counties. But the comparison group was different. Non-attended and non-attended. This is the biggest city, and this is sparsely populated areas. Nevertheless, among those who came to screening, and that's about 80 to 85% of all women, here is the benefit. Enormous benefit. Last year, 2 enormously important articles were published. Ours, I just showed you. Those women who don't come to screening but get the most modern therapeutic regimens are not going to benefit. And this one should not shock you. Multi-center trial in the United States of America, published in New England Journal of Medicine. Dr. Sparano showed that if you study the 21 genes, then you find out that 80 to 85% of those who got chemotherapy should not get it. So the modern treatment is going to be precision medicine. Screening has made possible early detection. And now we have substantial evidence. Local regional therapy is effective in these cases. Adjuvant treatment should not be used. I wrote this 27 years ago, and nobody listened. At last, now we have 2 evidences, and it should change because, dear colleagues, no treatment is going to stop this train. And that phase in advanced disease. But the same treatment is life-saving when you and me deliver the disease in this age. So on the population basis, there is little evidence for a significant mortality benefit from new therapeutic methods if she doesn't come to screening. So the summary is, it's not how we treat the breast cancer patient, but when, early or late. Don't ever forget this final sentence. Early detection of breast cancer and treatment in early phase is the most important control mechanism for breast cancer death ever invented. My friend Blake Adey from Boston. And my other friend Connie Jones, who wrote, we have never been in a better position in past 5,000 years to deliver life-saving breast imaging services with such a high level of quality as we can today.